Welcome to the PODdoctors. I'm Dr. Damien Dauphinee, and I'm here with my partner,
Dr. Raafae Hussain.
And today we are going to talk about total ankle replacement, which is a pretty popular option for end-stage ankle arthritis. Patients that we probably would have fused a while back are now opting for the newer versions of these total ankle joints that we've been I think seeing more patients that are requiring that or requesting that option over fusion for lots of different reasons, but primarily because they get range of motion.
So just a generic overview. We've talked about the ankle before, and if you haven't watched any of our older videos, the ankle is made up of 3 bones, all right? You have your tibia, which is the largest of the bones, your fibula, which is the side, small, thin bone, and then your talus. The talus is a small bone on the inside of the ankle, which sits there to, act as that mortise to glide through that ankle. The wear and tear on the ankle, luckily enough, the joint itself is very strong, very resilient. It can take a lot of wear and tear. Just some generic fun facts on that joint itself. The ankle joint sustains more load per surface area than any other joint in the body. Think about that. You're walking, running, jumping on these on joints here, and your knees and hips go out. And that's why we don't see a lot of ankle problems aside from like rolled ankles and stuff like that, sprains and whatnot. Ankle arthritis is not that common. But just with your acts of daily living, pretty much when walking, we expect 3 to 5 times your body weight to go on that ankle joint with force. And then with running, jumping, exercise, sports, etc., you can see 13 to 15 times your body weight with these type of activities. Pretty resilient joint. So what do we see? Patient comes in, ankle pain, they're getting some clicking, some aches and pains, just swelling throughout the day, crepitation on motion. That's that feels like I got sand in my joint type of feel. We see swelling, we see that crunchy sensation. We do our range of motion exams. Sometimes you'll even feel like a hard stop. It's like locked up, it's limited, and
ankle impingement syndrome.
Yeah, anterior impingement, posterior impingement, and sometimes they'll even have like a deformity, like some angulation deformity, just depending on how much wear and tear has been going on in that ankle.
And most of these folks who show up with x-rays that look like this have had some pretty significant injuries in their history.
Yeah, the last lady we just did, I guess second last, she had a motor vehicle accident. The one before that, I think, was a motorcycle accident. A lot of accident-based injuries, right. Traumatic injuries. But so, normal ankle joint, nice and clean. You can see the mortices on all sides of the joint. And when you have arthritis like this, you're literally bone on bone. The cartilage is completely gone. It could be angulated. It could pretty much, start drifting in to one side of the tibia. Typically, the tibia starts collapsing, and you'll start getting that angulation of that foot, and then obviously they can lead to foot problems. We talk about our treatment options as far as that goes. So conservatively, we spoke about this before, ankle pains, what can we do? Bracing, sleeves, lace-up ankle braces, strapping, shoe gear modification. There's a lot of options out there, but these are all pretty much bandaging the problem when you have an ankle that looks like what we just kind of looked at before.
Yeah, these are going to be more helpful for folks who've got an acute injury that we're trying to rehab. But yeah, once the joint is completely shot, then they either have pain or they don't. And if they don't have pain, they may not have enough motion to even have pain.
Yeah.
So the joint's locked up enough that they're not having problems. And we see those folks from time to time.
Literally this morning, I had a guy, exact same situation. He had an ankle fusion on the opposite side. His good side is super flat-footed. Completely toe turned out. But he's so stiff that you can't move that foot. It's pretty much fused in itself.
So he's not having a lot of pain.
No pain. Yeah. It doesn't bother him at all.
Yeah. So that's a unique situation.
Yeah.
But would not require surgery.
that takes years of pain, right. Tolerating pain leading up to that component.
To get through that, yeah.
Yeah. So conservatively, other options, we can do steroid shots, physical therapy, all the topical gels and creams and stuff. But these are, like I said, these are just bandaging the problem. They don't actually fix the actual problem. So we kind of dive into our surgical options. So surgically, if the ankle joint isn't that far off or far, you want to get a couple years on with the ankle, we can scope it out, clean it out as best as we can. There's no promises with these type of procedures because there's a lot of bony components to this. We can try to drill out any osteochondral defects, backfill anything we can, but sometimes we opt to do the fusion. So fusion used to be the gold standard. I'm a plate guy. I know some people like to use rods and screws and stuff. I just put this picture in there. But would go in, pretty much you can do it arthroscopically, a small incision open, and you pretty much open that up, clean it out, get all the articular surface off of it, that cartilage, all the synovial tissue, and pretty much get that bone-on-bone contact, but in great alignment, and then we fuse it together. I know you're a screw guy, right? You're a crossing screw guy?
Use it all. I mean, X-fix, internal fixation.
Yes. Yep.
It depends on the patient, their body habitus. I mean, if you got a 350-pound diabetic patient who's neuropathic, I'm going to put them in a frame.
Yeah.
But yeah, I think most folks who have the option today are requesting total ankle replacement over fusion for obvious reasons. Fusion means there's no motion left. And the downside is you're going to accelerate arthritis in the surrounding joints.
Yeah.
So the subtalar joint gets beat up faster. Tarsal joints get beat up faster. So it's not without some repercussions.
Knees and hips. I mean, everything has to make up that loss of joint mobility. So when we start talking about ankle joints, we start talking about, the recovery process and all that. But let's talk about some older joints before we dive into some newer joints.
Yeah, these were problematic to say the least. Thankfully, before my time.
So the old concept on ankle joint replacement, and generally speaking, ankle replacements are super new as far as joint replacements go. I think the oldest ones they're talking about from like the 60s and 70s, and I mean that's fairly new as far as joint replacements go. It was based on the concept of you want that round articular motion, that ball and socket joint. So there was a couple of cases where they would use a hip implant and they'd put that stem up the tibia and they'd do that weird angle thing into the talus, and that would be the new ankle joint. It would be like doing like a reverse shoulder replacement.
That's a lot of hardware, a lot of work.
I actually had a patient out, and I was searching for so long. I had a patient who had that. I looked through all my pictures and stuff that I can kind of figure out who it was. But when I find it, if you guys follow me on TikTok, I'll put it there. My TikTok name is The Podfather. But if I find it, I'll post it there. I know I had one. I just got to find it. But they worked well for a short time, and then a couple years down the road, it would get bad, and it would subside, it would slip. You'd start getting arthritis in the joints. They didn't work out well. One, for the fact that you don't want to do a ball and socket joint in the ankle, and two, what they would do is they would have a metallic implant on one side, which wouldn't sit well. You'd have to cement it in, and then you would have a plastic, what's it called? High density poly whatever plastic in there, and that wouldn't work well because that wouldn't stick to bone either, and they'd cement that side in, and both sides would fail, and they'd be back at square one. It's
not the easiest joint to replicate.
Yeah,
the motion of the ankle joint is not. It's not a ganglymus joint like the knee. It's a joint motion that is triplanar and is difficult to replicate. So part of the reason why some of these failed.
Yeah. And
you can see in that middle picture the subsidence where that thing is now completely in valgus.
Yeah.
And that's a mess.
So as progression went on, they started using both sides with a poly insert on the inside. They got better. A real popular one, which is still around right now, was the Star. The Star total ankle was pretty much like top of its class for, I don't know, the better part of the early 2000s, and still is around today, starting to phase out of popularity. But the unique thing about the Star, and there was another one like it that wasn't FDA approved in the US. It was something BP, some, I don't know, Spanish or French word, I forgot what it was. But they would have a mobile bearing. So you would have the tibial component on the top side, and then the talar component on the bottom side. The talar component, where it would articulate with the poly, would be in a smooth pathway, a guided pathway. But the tibial component would be flat, so it can actually pivot and twist. And they worked out well for quite some time. But then when we got to our 15, 20, 25-year studies, the side effects, the subsidence, the loosening of the joint, implants, they started showing up more and more and more. So they kind of started falling back to your classic construct for total joints, where it's locked in a controlled fashion, a constrained joint implant. So another one that came out around the same time as the STAR was the Integra, which is also still around today. And it started showing that the long-term effects of the Integra was actually a little bit better than the STARs. So a lot of implants started going in that favor. There was another one here that I put in just because, most total ankles, we'd go from the front, we'd go in, split it up in the front, clean up the joint, and you'd, impact those devices in there. But there was a company that Zimmer, I guess, acquired or whatever. They made their own implant. I don't know how that works, but they would come from the fibular side. So you'd go in from the side, you'd cut the fibula, you'd flop it back, and then you'd tap your implant in that way, which was a unique twist on doing the total ankles. But they had a lot more complications than they had success. So that kind of quickly fell out of favor. But yeah, my early training was all on the STAR. I mean, I pretty much did STARs. I did like 1 or 2 Integras, but vast majority of my stuff was STAR, and it worked really, really well. Patients loved it.
We were using the Salto Talaris, the French one. Mm-hmm.
Yeah. So the newer ones. The InBone actually is an older one. They just keep on revamping it and making it better and better. I want to say this is like their 4th or 5th iteration of it. The Infinity, this is the one that we use the most, I know. It works out really, really well. The Vantage total ankle and the Cadence total ankle, really, really good. I think the Cadence is made by Dr. Easley. Don't quote me on that. One of the two are made by Dr. Easley. He's the guy who wrote Foot and Ankle Reconstruction. Really, really good. Pretty much based on the same style. But they all have a solid tibia and talar component, metallic, and a locked-in poly that glides along those surfaces. They work out really, really well. The only difference between all of these and the InBone is that the InBone, you actually have to put the stem in, so we can't tap it in from the front of the ankle. You actually have to come in from the bottom, which is a additional step.
And you have to build it up.
You have to build it up piece by piece.
Yeah, piece
like
by
Legos.
piece. Yeah, they're really kind of fun to do.
So as far as the surgery for these went, and these are still today, so currently the standard of surgical technique, or whatever you want to call it, is you'd do a long incision in the front, and then you'd put these pins and wires all the way up from your front of the ankle, and then you'd have 1 or 2 on the front of the knee, right across that little tibial tuberosity that you have approximately. And the alignment and the angulation and everything that you do, you'd have to do intra-op, which, it's based on users at that point, and still is, right? So we'd adjust the frontal plane alignment, we'd get the sagittal plane alignment, we'd get the transverse plane alignment, and then you'd go back over and over, and that's a good 30 to 45 minutes of just aligning everything to make sure it's right. And you get multiple x-rays, a lot of radiation, etc. And now the newer version that Right Medical / Stryker has come out with, and this is the one that we use the most, they use a 3D printed poly, plastic, whatever component that sits flush with the patient's front of the tibia and talus. I mean, how easy have these become? I mean,
as far as the jig systems are concerned, there's a big fiddle factor with most of them, and I've used several, and you align that well, and then you're going to put in your implant well, but just getting the alignment right with these jig systems can take an inordinate amount of time.
And it's very user dependent, right?
I would totally agree.
where we would, kind of like, oh, it needs to go up or back or front, like a little bit more valgus, a little bit more varus, and obviously the joint doesn't look like what they show in this picture here. This is a nice, healthy, clean joint.
Right.
The joint is collapsed. It's significantly dystrophic. So you're looking at a pretty much a joint that looks like it's been beat with a hammer, and then you're trying to align it to that joint surface, which is difficult in itself. So I think
the 3D printed option for these templates has really made a huge difference in that those templates literally fit the anatomy based on that three-dimensional CT. So 3D printing these and making them individualized for every patient, I think has made a huge difference and allows us to put our pins in where they need to go based on the patient's anatomy, own individual anatomy. So instead of press fitting everything and sort of pigeonholing every patient into a small subset of equipment, now you've got equipment that's built just for that patient to help you align their joint with their anatomy. And I think it's made a huge difference. Yeah.
Aside from that, you're putting less holes into the tibia, where there's been a couple of papers where, you put these holes in K-wires and Steinman pins and things in, and you're like, all right, that's the least of their problems, right? But what ends up happening is that joint capsule, you're moving that fluid all around there, and you end up washing out those joints. There's been a couple papers where they show long-term studies, CT scans, where you expect those joints, those little pinholes to fill in, but you're actually technically washing out those joints every time they move that ankle. And they never end up filling in. And you can actually erode part of those holes larger and larger.
So maybe contributing to subsidence.
Yeah, 100%. So, these work out well. Like I said, they cut down on x-rays, they're less radiation. They cut down on tourniquet time. They cut down any user error that might go into this. A big factor of surgery and use of which ankle I'm going to use is based on, honestly, this. And I expect a lot of companies will probably start doing this. It's just, it's like a no-brainer type of surgery. Recovery. So recovery is pretty straightforward. Typically, we'll have them non-weight bearing for about 2 to 4 weeks. Typically, around that 3 to 4 week mark, we'll have them start putting weight on that boot. They, try using crutches or a walker, tripod gait. The incisions are long, but they heal up very, very well.
And we've incorporated some tricks from time to time with the incisional vacs.
Yeah, a little pico vacs.
Pico vacs. I think several authors have suggested using things like umbilical cord underneath the incision line. Which unfortunately is not available at every facility. But I think we've had very few problems with incisional dehiscence with these patients because we're taking good care of the soft tissues. We're not tugging and pulling and beating up the incision line. And I think part of that has to do with the equipment that we're using. We're not having to use these big jigs and poke holes all over the place. And
the incisions are far, far smaller than the ones I would be making for the stars.
Yes. So totally agree, which makes a big difference. Yeah.
I like to use zip line or zip stitch or whatever they're called on the front of them. It looks like zip ties with steri strips attached to them. They work out really, really well. The front of the ankle, you have a lot of tendons, so chance of bowing one of the tendons in the front can put tension on the incision. So make sure layered closure and everything that we would do. A lot of people are starting to use these Takle ankle braces. I've read a couple of papers on this, more clinical studies than anything, but they would use the Takle ankle brace for when they start walking. And the nice thing about the brace is that they can do a locked up, a limited motion, and a full motion constraint type of situation. So you're phasing them to more advanced movement as time goes on.
Even in their own shoes.
In their own shoes. So there's no height difference problems either.
Yeah, I think that's a great use for that product.
And then a big thing is physical therapy. With any type of total joint, you want to do physical therapy, early range of motion as early as possible. And in given time, I bet you a lot of these total ankles are going to be weight bearing, like literally day after surgery, like they do knees and hips and stuff.
Yeah, I think the technology has finally caught up with the need, and the need is only getting greater. With the folks that have had ankle fracture repairs 15, 20 years ago, and now the joints continue to break down. The car accident victims, people who have slip and fall injuries. And as they get older, the joint continues to break down. Even if it was fixed correctly, 15, 20 years ago, the post-traumatic ankle arthrosis can still happen. Yeah. So we're going to see more and more of this as our population continues to age.
Well, I mean, that's pretty much it for total ankle replacements. We will do a deep dive on some of our cases. We'll dive a little bit more aggressively into the surgical technique and what we kind of do, front, back, top, and forth and whatnot. But
see if we can dissect a video.
Yeah.
Yep.
That's the problem. The place we do our total ankles, they don't have the in-light cameras like we do with all our surgical cases. But we'll figure out a way to get some good videos going. It's pretty amazing, and the patients do phenomenally well. I had a patient come back. I think I told you this a couple weeks ago. One of my first total ankles came back, and we did it back. First total ankles since COVID, excuse me.
Yeah.
Because COVID kind of locked everything down. And so, I mean, she's almost 2 years out from her total ankle. And she came back, and I was like, oh, no, something's gone wrong. Something's gone, wonky and whatnot. Came in for toenail fungus. Didn't even come in for her ankle. So,
that's a beautiful post-op right there. Yeah. Yep. Excellent. Well, very good. Well, I looking forward to doing a little deeper dive with some of the videos that hopefully we'll be able to make with the help of our folks in the OR, and we'll expand on our discussion of total ankle replacement. Very good. Thanks, Dr. Hussain, and we will see you guys next time on the PODdoctors.